So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all once again to our Saturday head neck academic classes. Today's class will be taken by Dr. Anuj Kumar. Dr. Anuj is assistant professor in Department of Radiotherapy, Tata Memorial Center, Mumbai. He will be speaking on the role of radiotherapy in the management of advanced thyroid carcinomas. So I welcome you, Dr. Anuj. Please go ahead with your presentation. Hello, Anuj?
Good morning, ma'am. When can we start?
Yes, please. You are muted, Anuj. Hello? Hello?
Hello, good morning. Good morning, ma'am.
Hi, Anuj. You can share your screen.
Yeah, okay. Is my screen visible?
Yes, it is.
Okay. So can I start or should I wait for some more time?
No, please start. Yeah, people will keep on
Okay.
joining, so let us start.
Okay. Yeah, sure. Thank you. Good morning, everyone. So I will be talking today on the role of radiotherapy in management of advanced thyroid cancers. The flow of my presentation will be anatomy and patterns of spread, staging and classification, treatment overview of differentiated thyroid cancers, role of radiotherapy in thyroid cancers, various consensus guidelines that we have, and some of the important recommendations that we should know, the technique of external beam radiation therapy, the various target volumes we use, and the toxicities encountered, and summary and some take-home messages. So coming to the anatomy of thyroid gland. So the thyroid gland is a shield-shaped structure. So it comes from the Greek word thyroides, which means shield. So it is situated in front of the neck, and as per the boundaries, superiorly it reaches till the middle of the thyroid cartilage, inferiorly till the sixth tracheal ring. Anteriorly, if we see, it is surrounded by the strap muscles, followed by subcutaneous tissue and the skin. Posteriorly, we have the recurrent laryngeal nerve, the esophagus, trachea, etc. Laterally, we have the carotid artery and the internal jugular vein. And posteriorly, like I already told you, we also have the prevertebral fascia and the vertebral body. So here we can see the axial image, and down we can see the CT scan, that is an axial cut section of the thyroid gland, which is depicted in blue color. We have the trachea, we have the carotid artery, we have the internal jugular vein, and posteriorly we have the esophagus. So the thyroid gets its blood supply from the superior and the inferior thyroid arteries, and venous drainage from the superior, middle, and the inferior thyroid veins. Going to the lymph nodal drainage of thyroid cancers. So we know that the first echelon lymph node of thyroid cancers are the central compartment. That is the level 6, which is the pre-tracheal, paratracheal, pre-laryngeal group of lymph nodes, and the level 7, which is the upper mediastinal group of lymph nodes. For the second echelon, we have the middle and the lower cervical nodes. So when the thyroid cancer has a lymph nodal spread, it goes to the central compartment first, followed by the other lateral deep cervical nodes. Coming to the distant metastasis, lung is the most common site of distant mets, followed by the bone and brain. Now we will discuss about staging of thyroid cancers. So as per the T staging, it is divided into T1 to T4. T1 is divided into T1A and T1B. T1A is less than 1 centimeter. T1B is 1 to 2 centimeters. So T1 is less than 2 centimeter. T2, we have 2 to 4 centimeter tumor. When we go to T3, it is divided into T3A and T3B. So in T3A, we can see this picture is taken from the AJCC 8th edition. The tumor is more than 4 centimeter here, but it is not spreading into the surrounding structures. So that is T3A. And T3B is any size of tumor, but it invades only the strap muscles. So what are the strap muscles? We have the sternohyoid, sternothyroid, thyrohyoid, and the omohyoid muscles. Coming to T4, it is again divided into T4A and T4B. So T4A is still when the lesion is extensive but remains operable. And if it becomes inoperable, it becomes a T4B lesion. So we will again tell about T4A and B. This is from the AJCC 8th edition again. So we can see the cross-sectional image where we can see the T4A tumor invades subcutaneous soft tissues, the trachea and esophagus. And we have the T4B, which is the gross extrathyroidal extension happening, which reaches the prevertebral fascia, encasing the carotid artery, or sometimes the mediastinal vessels and vertebral body, etc. So this is the T staging of thyroid cancers. And coming to the nodal staging, so N0 is divided into N0A and B. So N0 is one or more cytologically confirmed or benign lymph nodes. So if the lymph nodes are benign and if it is cytologically confirmed, then it is an N0A. N0B is there is no radiological or clinical evidence of locoregional lymph nodal metastasis. Coming to N1, as we already told the lymph nodal spread, N1A is divided into A and N1 is divided into N1A and B. N1A is metastasis to the central compartment nodes, that is the pretracheal, paratracheal, prelaryngeal or the Delphian nodes, upper mediastinal nodes, etc., which can be unilateral or bilateral, and N1B, which is metastasis to the other lateral group of neck nodes and the retropharyngeal lymph nodes. So after this, we come to the classification of thyroid cancer. This representation is taken from Perez textbook of radiation oncology. And we have the thyroid cancers which are divided as per their cell of origin. So here we can see the thyroid is made up of thyroid follicles, which is the structural and functional unit of the thyroid gland. And we have follicular cells, which is lined by a single a layer of cuboidal epithelium, and that is where the thyroid cancers arise from when we talk about follicular epithelial cells, and we have the parafollicular C cells from where the medullary cancers arises. So when we divide this, it is divided, the follicular epithelial cell neoplasms are divided into well-differentiated, poorly differentiated, and undifferentiated cancers. In well-differentiated, we have the papillary thyroid cancer and its various variants that includes the classic follicular variant, oncocytic variant, and various unfavorable histologies that include diffuse sclerosing, tall cell, columnar cell, hobnail, etc. And the follicular cell that has classic and Hürthle cell carcinoma. We have the poorly differentiated tumors that is also named as insular carcinoma, and the undifferentiated thyroid cancers, which is anaplastic carcinoma. So these are towards the more aggressive histologies when compared to the well-differentiated thyroid cancer. And as I told you, the cancers that arise from the parafollicular C cells, which is the medullary carcinoma of the thyroid. Then we have the classification based on ability to concentrate radioactive iodine. So when a patient comes, we should be very sure about which patients should be sent for radioactive iodine treatment. So this is again divided into the various classification based on what histology that particular patient is having in his report or her report. So we have thyroid cancers that concentrate radioactive iodine to a degree that may be curative. That includes the papillary thyroid carcinoma, the classical variant, the follicular variant, oncocytic variant, etc., and the follicular thyroid carcinoma. Then we have certain cancers that again concentrates radioactive iodine, but may not be to such an extent that we see for classical variants. So that includes the unfavorable variants like the diffuse sclerosing, tall cell, columnar cell, hobnail cell, Hürthle cell carcinoma, etc. Then there is a group that rarely concentrate iodine to a degree that is curative. That is poorly differentiated carcinoma, like I already mentioned, the insular carcinoma. And the ones that never concentrate iodine to a degree that is curative, that is the anaplastic and the medullary carcinoma of the thyroid. So coming to the broad treatment of differentiated thyroid cancers, the primary treatment of these cancers are surgical resection, followed by radioactive iodine and thyroxine supplementation. And well differentiated resectable thyroid cancers have got an excellent prognosis. And external beam radiation therapy for thyroid cancers is sometimes controversial and only selectively used. So we will discuss about that in detail in the following slides. And just to brush up, this class has already been taken by Dr. Suchismita and Dr. Shaik in their previous sessions. But just to tell some of the high risk indications of radioactive iodine use as per the ATA 2015 guidelines, that includes macroscopic invasion of tumor into the perithyroidal soft tissues or the gross extrathyroidal extension, incomplete resection, distant metastasis, high serum thyroglobulin levels, pathological N1 with lymph nodes having more than 3 centimeter in largest dimension, and follicular thyroid cancers with multiple foci of vascular invasion. And these are the latest NCCN 2023 guidelines that talk about use of radioactive iodine, which is selectively used and typically recommended, again, which is similar to what we discussed for the ATA guidelines. That is significant N1B disease, gross extrathyroidal extension, tumor more than 4 centimeter, post-operative thyroglobulin more than 10 nanogram per ml, bulky or positive lymph nodes more than 5 vascular invasion, and known or suspected distant metastasis at presentation. So coming to radiation therapy as such in thyroid cancers, there are various issues. So we know that the evidence for external beam radiation in thyroid cancers is mixed because we have lack of randomized evidence. And the data that we have is mostly from various retrospective studies. And those have included multiple histological subtypes. There are variable primary endpoints, and different techniques of radiation has been used, and which are mostly the conventional ones used. So that is why these are some of the issues that we face while we discuss on EBRT in thyroid cancers. And this is a broad indication chart showing the use of radiation therapy in thyroid cancers. So in definitive setting, when we use, it is mostly in the unresectable and the palliative setting. Adjuvant, we have various adverse prognostic factors that includes gross residual disease after surgery, recurrent cancers, radioactive iodine refractory tumors, certain adverse other pathological factors that we will discuss, like I told, regarding the various aggressive histologies, etc. And in palliative setting, we use RT for lesions in the bone or the brain metastasis, etc. So these indications have been taken from the British Thyroid Association and the Royal College of Physician guidelines. It just explains the previous chart in a bit more detail. So we have the primary treatment that is for unresectable tumors that do not concentrate radioactive iodine. We have unresectable bulky tumors that are where we give this in addition to radioactive iodine treatment. And in adjuvant treatment, we have when we have gross evidence of local tumor invasion like macroscopic or microscopic residual disease, when there is failure to concentrate radioactive iodine, extensive T4 disease, patients over 60 years of age, another very important prognostic factor, with extensive extranodal spread after optimal surgery, even in the absence of residual disease. So these are some of the indications that are used while we decide treatment for thyroid
Till
cancers.
discharge today. Oh.
Coming to palliative treatment, we have various indications, including bone metastasis, cerebral metastasis, sometimes lymph nodes that are fungating, stridor, dysphagia, etc. Mostly palliative treatment is used for treatment of bone and brain metastasis.
ये कोई फायदा नहीं है कर
Coming
देंगे
to, coming to external beam radiotherapy, this is a review article that was published from the Royal Marsden. And here we can see the, I think someone is speaking. Can they please
Sorry,
mute them?
Dr. Kriti,
Yeah.
please mute yourself. Yes, Anuj, please go ahead. Sorry for the
Yeah.
interruption.
No problem. Yeah, I'll continue. So we have a review article that was published from the Royal Marsden on external beam radiation therapy for thyroid cancers in differentiated thyroid cancers. And over the years, we can see some of the indications where thyroid, like where EBRT has been used in thyroid cancers, and we can see the primary endpoints has been mostly loco-regional control or cause-specific survival or local recurrence, relapse rates, etc. So here we can see some of the broad indications again, like lymph node positive, gross extrathyroidal extension, macroscopic or microscopic residual disease, extracapsular tumor invasion, etc. So we can see that the indications are varied and there are no definite recommendations, like we don't have level 1 evidence for telling that, okay, this patient requires treatment. So that is why it is important to know some of the important uh, consensus guidelines that have come for thyroid cancers, which will be the main focus of my talk today. So I will be discussing some of the important recommendations that have come from various like various places, including the American Thyroid Association, British Thyroid Association, NCCN, etc. So the main consensus guidelines I'll be talking about is the 2015 ATA. Then we have the 2021 ATA for anaplastic thyroid cancer, 2015 for the differentiated ones. Then we have the medullary thyroid cancer guidelines again by the ATA, which was revised 2015. Then some recommendations that have come from the American Head and Neck Society, the British Thyroid Association guidelines for management of thyroid cancer, and the latest NCCN guidelines, which recommends about the use of external beam radiation therapy in thyroid cancers. So we will go one by one on each of these recommendations. So coming to the 2015 ATA guidelines for differentiated thyroid cancer. So there are multiple recommendations, and when we go through them, the recommendation 60 that tells about the role of adjuvant EBRT. So they mention that there is no role of routine adjuvant external beam radiation therapy to the neck in patients with differentiated thyroid cancers after initial complete surgical removal of the tumor. So if you have a tumor in the thyroid that has been completely excised, then there is no role of adjuvant EBRT. So that is the first recommendation with respect to external beam radiation therapy that has come up in the ATA guidelines 2015, and which is followed by, and one of the studies which I would like to quote is a study that was published from Hong Kong. It was a large study with 842 patients from the Queen Elizabeth Hospital, Hong Kong. One of the important studies discussed by Chow et al. We can see that when there is gross residual disease after surgery, then the indication or recommendation for giving external beam radiation therapy is much higher. We can see that the various parameters, the cause-specific survival, freedom from distant metastasis, and loco-regional control improves when we give radiation therapy. So in these situations, when there is gross residual disease, it will benefit with giving external beam radiation therapy in the adjuvant setting. And coming to recommendation 72, when technically feasible, surgery for aerodigestive invasive disease is recommended in combination with radioactive iodine and or external beam radiation therapy. So here, what we try to tell is that the aerodigestive invasive disease, that is involvement of the trachea or esophagus, when that shows involvement, when these structures show involvement in a set of patients, they may benefit with addition of EBRT along with or without a radioactive iodine. So one of the studies which was published by Kim et al., again a big retrospective study from Korea, and which had 1,098 thyroid cancer patients with 6% having tracheal invasion. We can see in this table that OP is for operation and OP plus RT is surgery followed by radiotherapy. So in microscopic as well as macroscopic residual disease, so this shows this is when the trachea is involved. We can see that addition of external beam radiation therapy has again caused significant benefit in terms of local failure for this group of patients. So we can see from here it is it is quite evident that when there is a gross or microscopic residual disease, addition of EBRT when there is tracheal involvement will benefit such patients. Then coming to another more recent study on locally advanced thyroid cancers, again, which mentions that in terms of disease-free survival, there is a role or benefit with addition of external beam radiation therapy, especially in patients who have tracheal or esophageal invasion even after treatment with aggressive surgical resection. So these are the two indications. Once more, I'll tell. So when there is complete surgical removal of the tumor, there is no role of adjuvant EBRT. And when there is involvement of the aerodigestive tract, then there may be a benefit with addition of EBRT. So these are the two recommendations with respect to localized treatment of thyroid cancers in the ATA guidelines. Then when we see about the next indications for external beam radiation therapy, it mentions about the metastatic setting. So in metastatic setting, you can use what is called as the stereotactic radiation, or what we call as SBRT, which is stereotactic body radiotherapy, which uses high dose radiation in a short span of time. So these are used in distant metastasis. Like I told you already, the most common site of Mets will be the one of the most common site of Met is the bone, and we also have brain Mets. So here we can use SBRT when we have a bone Met, and we should selectively use that modality depending upon what histology and what infiltration of the surrounding structures it has. So that is why this recommendation is for SBRT is for distant metastasis. And it is ideal that we initiate this treatment prior to initiation of systematic treatment, because we can relieve the patient symptomatically or reduce the risk of local complications. And that is what is recommended by the ATA. And this recommendation 94 that again mentioned that in radioactive iodine avid cancers, like for example, if there is a radioactive iodine avid CNS metastasis that occurs, then we can give EBRT prior to the radiation therapy. Again, the reason for that, what they have mentioned is that there can be a TSH induced increase in tumor size and RAI induced inflammatory response. So these are the recommendations in the metastatic setting that is given by the ATA. So again, to summarize, we use SBRT for distant metastasis, and mainly we use it for bone metastasis. And when we use for CNS metastasis, depending upon the number of tumors, if it is very limited number of tumors, SRS stereotactic radiosurgery can be used on, and if there are multiple Mets, there will be whole brain radiation that will be given in such setting. So that sums up about the indications that have been given in the ATA 2015. Now we come to one of the proposed scoring system that comes from the French group. So this paper was published by the PMH, the Princess Margaret Hospital, and we can see some of the risk factors here that indicates more towards giving EBRT in certain set of patients. So here we can see age more than 60. That is a bad prognostic factor. Gender, males definitely a bad prognostic factor when compared to females. If it is resectable, then it is good. But if it is unresectable, again, it is a very bad prognostic factor. Then involvement of extra capsular spread, nodal spread, ENE, again, it is a bad factor. Other adverse factors includes extrathyroidal extension, that is T4 more than T3. Then when there is gross residual disease over microscopic residual disease, various histological variants, already mentioned, the aggressive ones, like the tall cell, Hurthl cell, columnar cell, diffuse sclerosing, etc. Then recurrent disease. When we have recurrent disease where it is difficult for surgically salvaging, then again, there is it becomes a bad prognostic factor, and it may indicate towards giving external beam radiotherapy if feasible. And tumors which are radioactive iodine refractory, like when there is no radioactive iodine fixation, then again, that becomes an adverse prognostic factor. So from this proposed scoring system, we can see that unresectable tumors, gross residual disease, and tumors which are radioactive iodine refractory are among the most adverse prognostic factors we consider when we talk about external beam radiation therapy. So score more than 4 in this was told as EBRT can be discussed, and score more than 6 EBRT is mostly recommended. So these are some good scoring system that can be used when we want to decide about giving adjuvant treatment or not. Then we come to the British Thyroid Association guidelines for management of thyroid cancer. In this, they have told the indications again for, so if we see various guidelines, most of them talk more or less the similar things, but then there are slight differences. Some explain certain points in greater detail, some explain something else. So that's why overall, if we see the recommendations, when we finally come to, it is almost the same indications that every guideline is trying to tell us. So here indication for considering adjuvant EBRT is again macroscopic residual disease, failure to concentrate radioactive iodine. And primary management when we use with EBRT is mostly in the palliative setting, which is unresectable disease in differentiated thyroid cancers. And there is there is one of the recommendations that talks about timing of EBRT with relation to giving radioactive iodine. So sometimes we have a confusion whether we have to give radioactive iodine before EBRT or radioactive iodine after EBRT. So this particular sentence is mentioned in the British Thyroid Association guidelines, gives a little bit more of clarity. So ideally, the timing is not well evidenced, and EBRT has been used postoperatively following radioactive iodine to obviate the concerns of a stunning effect of EBRT on thyroid cells. So what is stunning effect? So stunning is a phenomenon of reducing iodine 131 uptaking activity by the residual or metastatic tissue after thyroid surgery. So that is why when we use a radioactive iodine, we should be using it either, like we have to decide whether to use. So this is the reason what they told, the stunning effect that is caused by EBRT is one of the reasons why we give a radioactive iodine in thyroid cancers. Sorry. Yeah. So in this setting, and when it is given prior to, so if residual disease presents a threat to critical structures such as the airway, then EBRT should be considered prior to I-131. So I hope this is clear when we recommend EBRT as per the timing of radioactive iodine. So these are some of the important indications that has come from the British Thyroid Association. Again, coming to the NCCN guidelines of thyroid cancers. So the NCCN guidelines tells about the gross residual disease or unresectable disease. This is when you should consider external beam radiation therapy depending upon the avidity of radioactive iodine also. So when it is an unresectable disease, so this is for the papillary as well as the follicular thyroid cancers, they have given similar recommendations with respect to giving external beam radiation therapy. So only for unresectable and when there is gross residual disease. And mostly if it is an unresectable, then mostly goes towards a palliative treatment, depending upon the infiltration and the disease extension. So again, in the distant metastasis setting, again, it is recommended that we can either use local resection. For example, if there is a distant met, you can either use surgery or you can use modalities like radiation therapy if there are multiple metastatic lesions. So those that sums up what is given in NCCN guidelines on EBRT. So we talked about the ATA 2015, the British Thyroid Association 2014, and the NCCN guidelines 2023. And these are some of the practice guidelines that have been given by the AHNS, the American Head and Neck Society for Differentiated Thyroid Cancers. And out of this, again, there are 4 recommendations. So recommendation 1 tells that EBRT is recommended with gross residual unresectable regional disease, except for patients less than 45 years and if it is radioactive avidity. So we know that younger patients have a better prognosis and radioactive iodine avid tumors have a better prognosis. and it should not be routinely used. The recommendation 2, it should not be routinely used as an adjuvant treatment after complete resection of the gross disease. So that is the second recommendation. The third recommendation tells that after complete resection, it can be considered in patients who are older than 45 and with likelihood of microscopic residual disease and low likelihood of responding to RI. So again, this is the third recommendation that has been given from the American Head and Neck Society. And the recommendation 4, which tells that when you have cervical lymph node involvement, that should not be an indication for adjuvant EBRT. So many times there are doubts which come that this patient of thyroid cancer has got no other risk factors but has got multiple nodes with extranodal extension. So whether we should give radiation therapy or not. So when these are actually tumors which are very sensitive to radioactive iodine, and surgery with radioactive iodine gives excellent prognosis already. So that is why when we add a modality, we should always be careful what are we going to benefit or achieve by doing this. Okay, then coming to the planning of EBRT, we simulate the patient in head first supine position, neutral neck rest, arms by side with a thermoplastic mold. And it is important to know what are the target volumes that we use while we consider for adjuvant treatment. So the target volume should include the thyroid bed. That is usually we start from the hyoid to the sternal notch, both the carotid sheaths, the front of the vertebral body, including the tracheoesophageal groove, and the draining lymph node. So we have already mentioned that the first echelon and the second echelon group, what is those group of lymph nodes? We have the pre-paratracheal, pre-laryngeal, and the upper mediastinal and the lateral cervical nodes, depending upon their involvement. So IMRT is the standard delivery technique that is used because of various benefits that we have in terms of reduction of toxicities and in terms of coverage, so that we can reduce doses to certain structures like the spinal cord, the parotid glands, etc. And also it gives a more conformal dose distribution. So here when we talk about EBRT, we talk about the target volumes, the thyroid bed and the draining lymph nodes with IMRT as the preferred technique. Then coming to what doses we use for external beam radiation therapy. Again, as per the recommendations, when we have gross disease, we give the full radical dose, that is 70 gray in 35 fractions when we use. When there is margin positivity, like if we have margins that are very close, or if it is positive, then again we tend to give higher doses to about 64 to 66 gray. And 60 gray is the adjuvant dose. Like if we have a completely resected tumor and we don't have gross residual disease, again we give the 60 gray dose. That is that again, like I told earlier, we include the thyroid bed, the tracheoesophageal groove, and the level 6 cervical nodes and the lateral nodes based on their lymph node involvement. And 54 gray is for the areas of microscopic disease. Mostly that includes the lateral group of neck nodes and the retropharyngeal. So we this like a pictorial representation gives an idea about what happens in conventional technique and IMRT. So here we use X-rays to simulate, like I already mentioned, simulation followed by X-ray, and then we draw the portals, and then we decide what field we have to treat. And in IMRT, it uses more complex planning with physics and gives a better dose distribution. I'm not going into too much of details into the planning aspect. I will just show some pictures that will show the difference between what we achieve through IMRT and what we achieve with conventional RT for the benefit of the residents. And here we can see with conventional RT that mostly like we can see a through and through dose distribution. This is the 95% dose distribution at various levels. Here we can see at the top slices there is an underdosage more medially occurring, and we can see the parotids are in the field. Here we can see through IMRT technique, even in the earlier one, we can see we have very well covered the thyroid bed, the involved lymph nodes. And here we can see how well the parotid is paired when we use IMRT. And here again, another slide that shows what difference again, decreased dose to the spinal cord. So these are some of the benefits that we will get by using advanced modality of treatment. So here we can see another representation in the coronal imaging that shows how different it is when we treat with IMRT when compared to conventional treatment. So some of the acute and late effects of radiation therapy, that is acute, that includes moderate skin erythema. There can be some dry desquamation. Rarely we see some moist desquamation. There can be mucositis of the esophagus, trachea, or the larynx, dysphagia, etc. And the late toxicities that includes skin telangiectasias, skin pigmentation, dry mouth, esophageal stricture, etc. that is seen not very commonly. So we talked about the indications for differentiated thyroid cancers from the various guidelines that I had enumerated in the previous slides. I will also discuss about the other variants of thyroid cancer, that is the anaplastic thyroid cancer and the medullary thyroid cancer. So this is from the 2021 ATA guidelines for ATCs, and this is a flowchart that gives what treatment we give in locally advanced anaplastic thyroid cancers. So again, it is divided into stage 4A and 4B. So in 4A, we encourage definitive intent therapy, and if surgery is feasible, it should be surgery followed by adjuvant treatment. So whenever surgery is possible, if we can achieve an R0 or R1 resection, then following that, we should decide about adjuvant treatment. So after surgery, we should again be giving adjuvant treatment in form of radiation therapy plus minus chemotherapy, which can be taxanes or with platin or anthracycline. And so this happens in resectable disease, surgery followed by adjuvant RT with or without chemotherapy. And if it is a 4B disease, again we see for resectability and do various IHCs, and one of the important markers is the BRAF V600E mutation. So if we have mutation that are present, then we can give targeted therapy. For example, if there is a BRAF V600E mutation present, then the patient can be given like dabrafenib, trametinib, etc. And if there is a good response, then again it should be surgery followed by adjuvant treatment. And if this doesn't respond, then it goes towards either palliative chemo or palliative radiation. So there are certain other targeted mutations also, like we talk about the ALK, NTRK, and the RET fusions. And if those are positive, then targeted therapy has to be given as per that IHC that has come out to be positive. So this is for stage 4A and 4B ATC, again from the ATA 2021. And treatment of stage 4C. Stage 4C, again, it is metastatic disease. We have to first decide whether aggressive treatment is required or not, depending upon the spread of the disease. And if we are not planning for aggressive treatment, then it is mostly best supportive care. And if we are doing aggressive treatment, then we should also be doing the various mutations, like we already discussed, the BRAF V600E, depending upon whether we can give a targeted therapy or not, and again see whether there is a favorable response or not, and consolidate with the further treatment accordingly. And again, these are the recommendations that have been given by the ATA 2021 that mentions that following R0 or R1 resection, adjuvant treatment is necessitated with standard fractionation IMRT with concurrent systemic therapy. And the recommendation 15 that tells that again in unresectable tumors, advisable to use IMRT again. So there are various good practice statements that mention about whether how long you can give the radiation treatment. So we know that anaplastic thyroid cancers are not like differentiated, and they are more aggressive ones. So we have to initiate radiation therapy as early as possible. So that is why they have given a good practice statement telling that the radiation therapy should begin no later than 6 weeks after surgery. Then coming to the other recommendations that have come, again, what I mentioned in the flow chart, they have told that in unresectable disease or potentially resectable disease, if there is a targeted mutation that is present, give targeted therapy, see for the response. And if it is resectable, go ahead with surgery. And if it is not resectable, then again, if you are treating, either in the after a resection or not, IMRT is the recommended modality of treatment. Then same, what about again they have explained the recommendations, what has been given in the table, if there is a targetable mutation or not. So this sums up the ATA 2021 guidelines for thyroid cancer in terms of local disease treatment. And when we talk about distant metastasis, like here in bone metastasis, when we encounter these, again we recommend palliative radiotherapy. We will again decide the dose fractionation, whether we have to go for a conventional dose fractionation or a stereotactic dose fractionation, depending upon the cases. And if there is a cord compression, it is also recommended that some orthopedic fixation is done before initiation of palliative chemotherapy. So we can see that in most of the guidelines that we discussed, the strength of recommendation is mostly strong, but the evidence that we have is comparatively low when compare. So that is why these recommendations can be used based on individual patient setting. So that was about the anaplastic thyroid cancers. Then coming to the last part, that is the role of EBRT in medullary thyroid cancers. So that is the 2015 guidelines again on revised ATA in MTCs. And here we can see that in the presence of extensive regional or metastatic disease, we tend to, if the disease is not resectable, if it is not completely resectable, because these are aggressive tumors, there can be surgery which will be less aggressive that can be done, especially to preserve speech, swallowing, parathyroid function, shoulder mobility, etc. But mostly when there are resectable tumors, we do complete resection followed by adjuvant treatment based on indications. But because they have given this as one of the recommendations, I am discussing about this, and EBRT and non-surgical therapies depending upon the resection, resectability or not. And coming to the next recommendation, that is the recommendation on adjuvant EBRT in medullary thyroid cancers. These should be considered when there is a high risk of local recurrence again. So if it is a microscopic or macroscopic residual disease that is present when there is extrathyroidal extension, or there is extensive lymph nodal metastasis, or at the risk of airway obstruction, these are some of the indications with high level of local recurrence and more aggression. That sums up the medullary thyroid cancers as well. So coming to the take-home messages. So as we know, EBRT is not a well-established treatment modality in thyroid cancers. I have discussed about the various consensus guidelines and what are the various recommendations provided by each one of them with respect to EBRT. We know that it is not so much detail. It is not in so much of detail because we know the recommendations are sparse and the evidence is not very good in terms of the studies that we have. And these are the various important risk factors, like we have to consider the age of the patient. For example, like I already mentioned, if the patient's age group is more than 55, so that is why the AJCC 8th edition have given a cutoff of 55 for describing the various prognostic groups. So if the patient is elderly, that is a negative prognostic factor. Then resectability. So if there is a resectable tumor, we have to uh, subject the patient to surgery, then followed by adjuvant treatment only based on indications if it is really required. So if the disease is resectable, then there is no role of adjuvant EBRT in differentiated thyroid cancers. Then avidity to radioactive iodine. Mention the various histologies that are avid, that concentrate radioactive iodine, like the differentiated cancers, even the aggressive histologies, except for the ones that are the poorly differentiated one, or the insular carcinoma, then the anaplastic ones and the medullary carcinomas that completely do not concentrate radioactive iodine. Then residual disease. If you have gross residual disease, there are indications for giving adjuvant treatment. Or when there is recurrent disease. So if the patient undergoes surgery, if it is not salvageable, if the patient has already had multiple recurrences, so for giving a better local control, we may consider giving adjuvant treatment in that setting. In gross extrathyroidal extension, again, there are various, we have to consider many of the criteria together when we decide adjuvant treatment, so that gross ET again is not a lone indication for adjuvant treatment. Because again, if it is a complete excision, they are tumors that will respond well to radioactive iodine. So if you do surgery followed by radioactive iodine, that itself will give an excellent prognosis to the patient. So various high-risk histologies, we have seen the tall cell, the columnar cell, the hobnail variant, etc. Even these histologies, like I had already mentioned, if there are various multiple indications that is showing towards a higher risk of local recurrence, then we can maybe add local treatment in the form of EBRT. Extranodal extension also the same way. If it is completely resected and RAI avid, then we can proceed with that without giving adjuvant EBRT. So when you select a patient for adjuvant treatment, uh, in terms of external beam radiation therapy, it is ideal to discuss these patients in multidisciplinary boards, because many times there is a confusion regarding whether we should give adjuvant treatment based on various aggressive features. So it is important that the surgical oncologist and the radiation oncologist decides what we have to do further for the patient, whether the patient is going to benefit or not. And important to understand is that we need to balance those outcomes. So we need to see if surgery and radioactive iodine is giving a very good prognosis to the patient in terms of overall survival also, then whether should we give EBRT or not, because I have already enumerated the various side effects that happens with EBRT both in the acute and the late setting. So whether should we give EBRT? Is it really recommended? What are the adverse events that the patient may have if you give EBRT? So when you have a modality, we have to very carefully use and selectively use it for those patients who need it the most. And we know that there are no randomized evidence that is there. So it will be further needed for establishing evidence. So we now also treat thyroid cancers with EBRT based on the various retrospective studies, series, consensus guidelines, recommendations, etc. And one thing I did not talk about is about proton therapy. Proton therapy also, it has not much of a use in terms of thyroid cancers, because we know that in this group of patients, even giving adjuvant EBRT, we don't know what is the benefit. So, but there are still studies, especially the small series of studies that has come from Mayo Clinic and all, that has shown some of the benefit in terms of local control for patients with recurrent thyroid cancers, etc. But as of now, we would not recommend to use this modality for thyroid cancers as per the current scenario. So this is all from my side. So I hope I have tried to tell some of the important indications and recommendations in terms of external beam radiation therapy in thyroid cancers. Thank you. And special thanks to Dr. Sarbani Ghosh-Laskar for giving the slides on the dose distributions. So thank you, everyone. And if you have any questions, please go ahead.
Yeah, thank you, Anuj. Excellent, very crisp and clear discussion on the topic. I think you have already included all the important points. If any questions, please put them on chat box. So I think this scoring system which you have come to, Anuj, this is actually excellent because in fact I felt this also is very objective way to assess actually. So if the scoring is more than 4 and more than 6, do you want to elaborate a bit on this? If there are any questions, we'll be taking them after that. Anuj, hello?
So I did, yeah. So I just told because it came as a part of a study that has been like described in literature. So we are not using it on a routine basis. This was just to show which are those risk factors that can give us some idea about who are those aggressive histologies or the or the ones who may benefit with the addition of EBRT. So I just told this to understand those recommendations. I can also see Sarbani ma'am in the audience. So Sarbani ma'am, if you have some thing to add on what I have told, please feel free to discuss, madam.
Thank you, Anuj, for that very comprehensive lecture. You've covered everything very well. My only addition to this is that if you look at the scoring system, it actually takes into account all that has been described with the various guidelines. And it just brings to focus the points that a tumor that is not resectable, the poor histologic variants. But then again, you can realize here that just because of a poor histology in a tumor that is otherwise resectable doesn't make it a high risk patient. So you have to realize and you have to take everything together when you decide on adjuvant radiotherapy. So primarily, it is important for us to assess the resectability of the tumor, the extension to the extrathyroidal tissues, especially the upper aerodigestive tract, and whether there is R plus resection. These are the most important points in differentiated thyroid cancers. And the other important thing that Anuj alluded to very nicely was the fact about when should you be using external beam radiotherapy in the setting of metastatic disease. Ideally, it should be utilized before surgery if you think there is going to be a collapse, compression, or pressure. Now, these symptoms would typically become very pronounced if the patient were to undergo surgery before external beam radiotherapy. So these are places where you should use external beam radiotherapy before doing surgery or RAI. So these are the only additional points that I would like to make. In addition, what I would also like to say is that when you have gross unresectable disease, though all guidelines say that that is one situation where you may like to use adjuvant radiotherapy, please remember that there is no evidence to say that radiotherapy in the presence of gross disease or gross unresectable disease is actually effective. At the most, it gives you some containment of disease for some time, but you hardly ever see responses that are dramatic. So please keep that also in mind. And the most important thing is surgery whenever possible, and then judicious use of external beam radiotherapy.
Yes, ma'am. Thank you. Ma'am, Poonam here. One question. Yeah, one thing I wanted to discuss with you is like we have seen, like you rightly said, the gross residual disease. That too, we don't know the effects. Actually, they are unpredictable. So, but in our experience, like at least my own experience, is that extracapsular spread in papillary CA nodes is not that common. Even if it is common, we usually get a R0 resection. So, do you think there is a place for, like, what is your experience, madam, for this? That should we be doing it for extracapsular extension when we have nodes, multiple nodes?
No, so the point is that again, disease that has been resected completely, even if the lateral lymph nodes have gross extracapsular extension, radiotherapy is not recommended. You should go ahead with RAI unless it is one of the adverse histologies where you think radioactive avidity is going to be poor. Otherwise, there is no indication for external beam radiotherapy, unlike other situations in the head and neck where you have squamous cell carcinomas with extracapsular extension, you'll jump in to give radiotherapy, but not in the situation of differentiated thyroid cancers. You will still go ahead with surgery, complete resection, and then follow it up with RAI.
Yes, ma'am.
Any other questions from anyone? I can't see any right now.
So I think if there are no more questions, I think your presentation was so comprehensive. All our questions have been already answered, Anuj. So, and rest, madam has already answered. Yeah. So I think with this, we conclude today's lecture. And thank you so much, Anuj and Sarbani madam, for today's lecture. Thank you so much.
Thank you. Thank you.
Thank you.